Today's topic will be the post-acute physician's role in the Bundled Payment for Care Improvement Initiative. So why are we having this discussion? As you're probably well aware, healthcare expenditures in this country are continuing to climb and currently are out of proportion to those of other developed countries. We are currently paying more than twice the average of the other developed countries, and what we're finding is that the population health that we're receiving for this level of spending is not significantly higher. How has CMS decided to address this problem? Multiple programs have been developed under the generic title of value-based purchasing, such things as Bpci, accountable care organizations, etc. These all fall into the category of value-based purchasing programs. And if you go to the Medicare regulations, you will find a lot of very confusing language describing the details of these programs. The simple way that I like to think about these programs is with one simple equation. Value equals quality over cost. And this is, in my mind, the most simple way to think about all of these value-based purchasing programs. CMS is looking for a way to achieve value in our healthcare program by increasing quality and decreasing cost. So specifically to Bpci, what is Bpci? This is a concept where 181 of our existing DRGs have now been collapsed into 48 clinical bundles. There are multiple programs that an organization can enroll in order to participate in Bpci. We are participating in Model 2. Some of your facilities are participating in Model 3. The difference is the episode of care initiation. An episode of care begins when a patient is admitted to an acute care hospital in Model 2 and is admitted by a team health or IPC physician, which then allows the patient to be enrolled in the team health IPC Model 2 program. This means that team health IPC are then responsible for the cost and the outcomes of this patient's care for the next 90-day period following discharge. What's Model 3? It's exactly the same, except the episode begins when a patient is admitted to a skilled nursing facility that is participating in the Bpci program. The patient is then tracked and is the responsibility of the skilled nursing facility for the next 90-day period. CMS has set target prices for each of these 90-day bundled periods. This is based on historical claims data and is the goal that we are hoping to achieve in managing these patients. At the end of the 90-day period, CMS does a retrospective look at the cost and the outcome of that 90-day management period, and then a true-up is performed. If we have produced a result that is a higher cost result, we, being Team Health and IPC, are responsible for paying back CMS the difference. If we have produced a lower cost result during that period, CMS will then write a check to Team Health IPC for the difference. During this period of time, all providers are paid on the same fee-for-service model that we've been paid over the last 30 years. So why is post-acute care getting attention in this model? If you look at this chart, you'll see the first bar represents the acute hospital stay, and that roughly represents 1/3 of the cost of a 90-day episode. The next two bars are skilled nursing care and readmissions. If you combine those two, those again represent about another 1/3 of the cost of this episode. So we're getting attention because we have direct control over bar number 2 and bar number 3, skilled nursing care and readmissions, that 1/3 of the bundle cost. Remedy is the convener that we've chosen to use in the bundled care program. Remedy functions as our intermediary with CMS. They are responsible for gathering data on our patients during their episodes, analyzing this data, and submitting this data both back to us and to CMS. Remedy also brings us multiple tools that we use in the Bpci program. And on the screen, you see one of the tools. This is something that Remedy calls the 4 levers. What can we as clinicians do to impact the cost of an episode of care? Lever number 1, choosing the correct next site of care for a patient. This is something that obviously happens on the acute side, but helps direct our acute physicians to choose the best site of care for a patient based on the patient's needs and cost and potential outcome. The next lever is SNF selection. By utilizing preferred skilled networks, we hope to partner with skilled nursing facilities that are also focusing on outcomes and cost measures. Again, this is a lever that is controlled on the acute side of our equation. Lever number 3, skilled nursing facility length of stay. This is one that we own in the post-acute space and is extremely important and is relevant in that we are being asked to manage patients to the appropriate length of stay in a skilled nursing facility. Lever number 4 is doing so while avoiding readmissions. And readmissions is, again, a lever that we are responsible for, and every effort needs to be taken to manage readmission potential appropriately. We will be addressing all of these levers in more detail in the future. One of the tools Remedy brings to us is a tool called Expected Length of Stay, ELOS guidelines. These are guidelines that were developed by Remedy, again based on historical claims data, and have shown how patients have been managed historically in a skilled setting based on their diagnosis and their bundle assignments. So the example you see on the screen is a major joint replacement of the lower extremity. This bundle contains 2 DRGs, and historically what Remedy has found is that the top 20% of performers in this bundle have managed patients with an 8 to 9 day stay in a skilled facility. So Remedy has taken that top 20% performers and used that now as our target for length of stay. This is a suggested target for any individual patient and is absolutely not a requirement, but is something that we can at least use as a tool to help more efficiently manage our patients. This also will be discussed in detail in the future. So how are we being measured in this program as providers? We're being measured on the development of post-acute networks, the utilization of post-acute networks, and those are 2 measurements that are mostly in the control of the acute providers and the Remedy organization. The next 2 metrics, appropriate post-acute length of stay and readmission rates, fall squarely on our shoulders. So what do? We do our best to manage appropriate length of stay. Again, we now have the ELOS guidelines that we can lean on, and we have a sense of when a patient is functionally ready to return to their living situation. We need to become much more aggressive advocates for our patients. The other thing we can do is work towards preventing readmissions and managing readmissions appropriately. There are many tools at our disposal for doing this, and in future modules we'll be addressing these in more detail. So, as this series progresses, you will be hearing different topics such as ELOS guidelines, appropriate readmission management, advanced care directives, skilled network development, home health network development, appropriate handoffs, and any other topics that you suggest that you would like to hear. I appreciate your attention and thank you very much for the work you do.